Okay, hi guys. I'm back with another video. This time it's a histopathology video. Thank you so much for showing so much love to the last video, which was on approach to a approach to lymph node lesions, where I discussed a basic in approach to IHCs, how you make up a mind ki which IHCs you need to put, which you don't need to put. Thank you so much. The video received a lot of views in a very short span of time. I'm overwhelmed, and I would hope that you would keep supporting me like that in future. So, since I take that to be a part of HematPath, and it was a discussion of HematPath, so now I am today this time going to take a histopath topic. So I'll be starting with lung. This was what my thesis was on when I was doing MD. So I have a special attachment to the field of lung pathology. So I'm going to be starting with lung as far as histopath lesions. I have done breast, I've done lymph nodes, so now it is lung. And the first major topic that I took after breast is lung. So I'll go like this, that today only discuss in 15 minutes grossing and some anatomy, the important points. Then I'll go to benign lesions, then I'll go to malignant lesions, then I'll cover whatever ancillary tests are left and whatever points I leave in between. The purpose of histopath is the same, to discuss with you pitfalls and things that I used to miss as a resident, not cover the entire course because you have really good lectures going on for that. There's no need for me to do it. If you have some questions, you can always approach me on Messenger like some of you always do, and I will try and sort it out. I will address it in the next video. But the point is to keep it crisp and concise so that even you don't get bored with the lecture. And I don't need to cover one individually everything. You all are smart enough to read and to know what is important. I'll keep telling you also what is important in histopath. But the purpose is to make you practically ready for the topic and to make you aware of where you might make a mistake. That's the purpose over here. So, in any type of grossing in histopath, what you will always be asked, especially in vivas, is the type of surgeries that you can come across. If it was breast, they'll ask you about type of mastectomies and biopsies that you can come across in breast. This is quite common when you are giving your gross viva. Okay, if the gross viva has uterus, then they're going to ask you about the anatomy of uterus and types of hysterectomies. Okay, so remember that if you are reading histopath and you are talking about an organ, then the gross is important for the gross viva. They'll always ask you about the type of surgeries and anatomical landmarks. Remember that that is a basic rule. So in lung, you might have pneumonectomies, that is removal of the entire lobe, sorry, the entire lung, right or left. Something has happened which requires one entire lung to be removed. Okay? Lobectomy is removal of one lobe of lung. You know there are 3 and 2 lobes. So removal of one lobe is lobectomy. Segmentectomy is lung is anatomically divided into multiple segments. I'll show you all these images abhi aage. And removal of one particular segment, and the pathologist and the surgeon is aware of where what segment lies, and removal of that one segment of a lobe is known as segmentectomy. Wedge resection is a triangular shaped resection of the entire. So I'm going from the complete removal to smaller specimens of the lung. Okay. And then there are biopsies and bowel fluids and pleural fluids, which we can use in cell block history, that is fluid making blocks, or as biopsies are used in histopath. So here you can see this is an entire lung. Okay. So removal of this one entire thing is known as pneumonectomies. Lobectomy is like, see over here in the right there are 3 lobes: upper, middle, and lower. And in the left there's upper, lower, and then there's an insular lobe over here, a small tongue shaped projection. ठीक है, ये याद रखना. And left के पीछे heart का impression आता है. So removal of any one lobe is known as lobectomy. Then there each lobe is divided into multiple segments. Okay, there are segments in each lobe. I'll show you the image ahead. Removal of one segment is known as segmentectomy. Then wedge biopsies are triangular biopsies from, say, any part wherever the lesion is, and then there are biopsies and bowel fluids. Okay. When you turn, and this is the anterior surface, and then there'll be a posterior surface. So when you turn the lung around in your grossing, you see the hilar area, and in the hilar area you need to identify the artery and the bronchi. Okay, you need to identify the artery, the vein, and the bronchi. And then there will be some lymph nodes, some perivascular, fibroglacinous tissues, etc. So but you have to see the vein, the artery, and the bronchi. These three things that you have to identify when you are looking at a gross of a lung. Okay. So if I take the anatomical image from letters, so here you are going to see what is this? This is the bronchus in yellow, fine. This is the right superior lobe bronchus, and this is the intermediate. This is entire structure is that of a bronchus, okay, and this is the intermediate bronchus. Then you are going to see a vein. See, this is this one over here, and then I am mistaken, sorry, then you're going to see the artery. Why has it been colored blue if it is the artery? Now you are going to read it, and this was given in your anatomy classes. Why is the artery labeled blue in lung? There's a pulmonary artery and then there's a bronchial artery. What does the pulmonary vein carry and what does the pulmonary artery carry? Very, 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 very important question. I'm giving you a hint, a bigger hint. One carries oxygenated blood, one carries deoxygenated blood. Hence, the color is red and blue. But why is the artery blue? And what is the difference between pulmonary artery and vein and bronchial arteries and veins? I am going to take up the answer in the next class. But this is very basic, confusing, yes, but very, very basic. So let us see how many of you can get to the answer. You can write in the comments if you know the answer. It is something very basic, something which is brought to your notice by the anatomist every time, by the physiologist every time. Let us see how many of us remember why in lung the artery is blue and the vein is red, and which artery is blue and which artery is red in lung. Okay, so here what you see is a pulmonary artery, again blue. Okay, and then this is the pulmonary vein. Okay, and then there are other structures. See now, this over here is a bronchial artery, not visible, but this artery is red actually. Okay, and this is a bronchial artery, but the larger diameter ones, the color has changed, and you will read up and answer why this has happened, and then there will be lymph nodes and pulmonary veins, etc. So over here, you remember this diagram from anatomy. We used to always, make this whenever the hilum of lung was asked, where they show you the bronchus, they show you the pulmonary artery. This is anterior, okay, of the right lung. Then they'll be show you the pulmonary vein, there'll be a pulmonary ligament. This is the anterior part, this is the posterior part. So how do you remember anterior to posterior? What was the mnemonic? It was VAB, VAB, vein, artery, and bronchus. And similar in left lung, again, here this was the artery, I mean the pulmonary vein, this was the pulmonary artery, and this was the bronchus. So going from anterior, I think the here the mnemonic was from posterior to anterior, and again it was bronchus, artery, and vein. Or you can also see anterior to posterior, it was vein, then comes the artery, okay, and then comes the bronchus. So anterior to posterior, from the in the hilum in both right and left, it is VAB, vein, artery, bronchus. Now what you need to remember is in right lung you're going to see two shadows of pulmonary, two holes for pulmonary artery, while in the left you are going to see one hole. In the vein there will be more than two. Here there will be only two, and then there's one single bronchus opening in both the sides, and the ligament going down over here, this thing, see this thing is the pulmonary ligament. Okay, so just remember anterior to posterior is VAB, and the number of arteries and veins is lesser on the left side as compared to the branches, is less on the left side as compared to right. So I told you I'll show you everything. So the different, if there's a lesion over here, see this, if there's a lesion over here, this in the lung. So this kind of a triangular resection, this is a wedge or a partial resection. Then all these A, B, C you see in both sides, these are segments. See this A and B, if both removed together is segmentectomy. Only one smaller part of a segment removed together is subsegmentectomy. Then there's partial resection. This I think this thing is partial resection, this line. Okay, and this, see, the entire segment has not been removed. Both the segment, part of both the segment have been removed. So this is known as partial resection, wedge resection, the V shaped. Okay, and then there's lobectomy. Same thing is shown here. This is lobectomy. Then there's bilobectomy, when two lobes are taken together. Pneumonectomy is the entire lung. Segmentectomy, when segments have been removed, and partial resection, as I showed you, part of segments have been removed. These segments are divided as per the blood supply and blood drainage from them. So depending on that, these segments have been divided into A, B, etc. Okay. And normally the resection, the pied and lobectomies, they are done by the fissures, the oblique and the horizontal and the longitudinal that the lung has. As you can see, going along the fissure on the left side, can you see an entire lobe being removed? So lobe depends on the direction of the fissures. Then there are segments depending on the supply, and then the ectomies, the tectomies depend on what part of the lung is being removed. Okay. Now, in lung, especially in lung tumors, if it is a benign lesion of lung, you can follow the basic grossing and reporting protocol that you follow in your lab. But for malignant lesions of the lung, you have to follow the CAP protocol. This is one of the most standard protocols that we follow, and this is how you are going to gross the lung. So in benign, I'll give you a basic first, that when a lung comes to you, then I'll take it later on. You have to check a few things grossly. Then you have to check in any large specimen, you have to check the weight. Then you have to describe outer, how it looks, any extra stitches, surgical sutures are there, etc. All that you have to mention. In lungs, in cases where it comes as an autopsy specimen, you also have to check if there's a death by drowning. Then you float the entire lung or part of the lung in water and see whether it settles or it sinks or it is floating. Mostly done with pieces of lung. You also take then I'll take all these points I'm telling you now आगे भी है, that when you are fixing a lung, then you start from the outer curvature, the outer part of the lung, and go up to the hilum. Don't and lobe it, at 1 centimeter. Don't cut it throughout. Don't slice it like in any haphazard direction. Maintain the orientation of the fissures and try to go parallel to it. Supposing you are taking the oblique fissure, try to go parallel to it. Don't cut in entirety. Don't detach it when you are fixing it. And first go towards the hilum, trace the bronchus, etc. Push formally in through it, so that inside also things can be fixed. Apart from testing for floating, sometimes we squeeze a part of the lung to see if air bubbles are coming out or not. If it is solid, dense, wet, no air bubbles are coming out, it might be due to drowning. Then there may be hemorrhage, etc. in the lung. So pink frothy bubbles might come out if you are squeezing the some part of the lung. So these are some gross, very practical things that you do when you look at the lung. But what does the CAP tell you to do when we are looking at a lung for grossing? We take the patient's clinical details like drowning, cancer, treatment, etc. We also should know what procedure has been carried out to document whether there's a fissure present or not. Is it a segment? Is it just a small biopsy? Is it entire lung specimen? We need to mention that. On the basis of that, can we identify the laterality of the specimen? It is always easier to identify the laterality if either the specimen is marked and the hilum is present. It is always because we know the hilum is posteriorly, so we can anatomically hold the lung in the correct position. And the apex goes above, and the diaphragmatic surface is below. Then site of the tumor, size of the tumor, this after taking the weight of the specimen. Then this is just for cancer, okay? Then this note is given there ki what is there in, I'll take it later on when I take malignancies. Okay, this is actually for microscopy. Then if there's a tumor, then is it multiple or single only in one lobe or in multiple lobes, one segment or together? And if you are cutting open the tumor after fixing it, do you see a uniform thickening around the air spaces, the areas which you open, or is it a well marked circular tumor? Is there a cavity in the tumor? All these give a direction towards whether it could be SCC or it could be a diabetic pattern tumor. Fine, and SCC is a cavitatory mass. A lot of necrosis occurs in SCC. Then small cell tumors are mostly in the bronchus area, 2 centimeter coin shape. More peripheral, plural, not plural, but more peripheral in position are adenocarcinomas. Fine. Lipidic pattern appears normally as thickening rather than a well-formed mass. Then comes the after grossing. This is the entire reporting protocol of CAP. Then once we have taken our section, so once you cut the lung, after noting these points down and observing them, what I do is I normally lobe it at 1 centimeter, keeping the direction of the fissure in mind. Fine. So supposing this is a lobe of lung I've received and there was a fissure over here which I can make out, then I'll just do it, make incisions like this. Supposing the tumor is over here, and I will inject formalin 1 day before, and then I'll keep this specimen in formalin to fix so that beach में भी formalin चला जाए. Then I'll take out one slice with tumor, and supposing this was the tumor, okay, यहाँ तक पूरा tumor है, so I'll just take this, I'll just change it to green now. I'll take this one slice, and then I'm going to take multiple sections from one slice, hence maintaining the orientation of the entire specimen received. And I'll also check the other these and these slices for extra findings which I might be getting. Calcification है, grittiness है, variegation है, तो वहां से एक extraction ले लिया. Now if I have this one slice in front of me with tumor over here, then I'll take 4 sections from lung and tumor. In the 4 sections, there'll be 2 purely tumor, 2 appearing normal lung and tumor, then some section from normal appearing lung. If I'm fortunate enough to have a bronchus, etc., on the in that section, I'll take section from that. If there are vessels, I'll take section from that. Why? Just to see if any invasion, etc., is there or not. Then I'll take section of the normal lung and pleura just as an extra, and carcinoma and pleura just to see the extent of invasion. Why normal lung pleura areas around the what shall I say, the tumor is needed is A, there's something called STAS, there's metastasis through airways, which is visible microscopically, not grossly. Second, if there's some AIS, etc., or a component of lebetic pattern which I might be missing, so I take these sections from nearby and exhaust this entire slice. So around say 4 plus 2 plus 2, 10 to 12 sections is needed. Then if there's extra soft tissue available, take section from that. Any lymph nodes submitted, take section from that. Okay. So after that, now once you see the microscopy, you will have to talk about the histological type. I'll take this later. Grade, stats, any pleural invasion, any lymphovascular invasion, direct invasion, and margin. Margin is you have to take sections from here also. Okay. Margin of the specimen and then margin of the tumor. This is the margin of the tumor. Okay. And then there's something called the margin of the specimen. This is the margin of the specimen. So I prefer taking sections here also and here also and labeling them as such. This is of more importance to see कि tumor यहाँ से कहीं invade तो नहीं कर रहा है. Sometimes I don't know, there may be some micro deposit being missed, so I also prefer taking sections from the margin of the specimen also if it is cancer and if they are marked. Okay, like in breast, you take margin of specimen also. Similarly, I do in lung. Okay, it is on you, but margin of the tumor is very important. Okay, जहाँ tumor खत्म हो रहा है, उसके और normal का भी जरूर लेके analyze करना है. ठीक है. Then if your specimen, आजकल there are a lot of concept of neoadjuvant chemotherapy. So if the specimen is coming to you after treatment, then this one problem of necrosis and tumor viability will come. You take similar sections. Also take sections जो soft and pulpy ना लग रहा है. Soft and pulpy means there's necrosis there. So you might take of course from necrosis and we can see हाँ 10% viability है cells की नहीं microscopy में. Also try and take sections from areas which are firm. It is always better to take sections from areas which are firm, as well as of course the necrosed area, to get a complete view of what the tumor type might be in that section. And nodes and extension of nodes are important, and then there's that AGCC classification. So now this is microscopic protocol. ये पूरा कैप है, कैप में आपको इन सब पॉइंट्स को मेंशन करना पड़ता है अगर दिख रहे हैं, नहीं दिख रहे हैं तो फिर you can delete it from the report. Okay, so this is actually microscopy. Cap का protocol is downloadable, you can start using it. It is very good and very concise. So see now and then you have to, if it is a plural based tumor or the tumor is protruding into the pleura, and you see this is a wedge section. You see, you look like a triangle. So what I was talking about is, see, this is the bread loaving I was talking about. हमने serial cuts ऐसे लगाए. यहाँ पे ब्रोंकस का कोई सवाल नहीं उठता है कि हमें हाइलर एरिया मिलेगा. तो बस आप सेक्शन में सीरियल कट्स लगा के इसमें बीच में कॉटन फॉर्मलिन में डिप करके एक रात छोड़ दो. Next morning when you come for grossing, this is how you are going to serially cut, and see this is how the sections will look. So if I am cutting through this place over here, so I'll get some tumor and a part of the normal section, and this is what we are going to submit for after trimming the section for microscopy. Okay. Again, they've shown you a section where they've bread loafed it. There are multiple ways of taking sections actually. Mostly everyone is cutting it parallelly and then taking sections. What they've done here is first they have cut it parallelly, then they've divided it into multiple. So this is the basic, right? You don't have to copy paste it, but this is how you do it. You can't, you just can't start going कि okay, the section है तो हम यहाँ से लेके बस हो गया. नहीं. First cut it parallel to see the extent and then take out one section, and then as I told you, margins are important. So this is just a little bit of anatomy where I wanted to tell you, I'll take it when I'm taking benign lesions, that remember, like I told you about the vein and artery, then another question, what is the barrier between the capillary and the airway spaces through which the blood filters and oxygen is exchanged? So it is a 6-layer barrier where you'll get the endothelial cells from the artery side. I'm going endothelial cells, then the basement membrane. Then there's some alveolar interstitium, then comes the epithelium basement membrane, and then comes the pneumocytes. Okay, and this 6 layers of there are total 6 layers. So 1, 2, 3, 4, 5, and what is the sixth? You are going to tell me. I think I missed it over here. So there are 6 layers through which the blood filters through. So it goes from the blood, then the endothelium, then endothelium ka basement membrane. Then comes to the interstitium, the alveolar interstitial surface. Then from the alveolar interstitium, it goes to the type 2 pneumocytes जिस पे rest कर रहे हैं, the basement membrane there, and then the type 2 pneumocyte, and then goes into the alveoli. And इसी तरीके से CO2 and O2 का exchange and nutrients का exchange होता है. So this is given in Ganong actually, so you can go ahead and read it. I've told you how to send test for drowning, then injection of formalin. ओके, स्टेपल लाइन एंड लंग बायोप्सी सेक्शन टेकन पर आजकल ना सूचर्स की जगह स्टेपल्स यूज होते हैं. तो इफ यू गेटिंग अ वेज बायोप्सी with a staple line, so supposing you get a wedge biopsy and there's this is the staple, यहाँ staplers लगे हुए हैं, ठीक है, ये staplers हैं, then you are going to not go like this but instead perpendicular to the staple line. This is how you are going to section. You are not going to section it like this. You are not going to do this. This is what this states. Then sometimes, not always, when you are getting a lung specimen, always demand a CT, because sometimes they what a clinician or radiologist might be missing an AIS or a lipidic pattern which appears very very faintly hazy, and you have the gross also in front of you where you might be seeing a thickening somewhere जो कि tumor से दूर है. Then when you corroborate it with your CT images, you can be sure that there's something over here and take a slice from there also. And if you're getting biopsies, at least get 6 pieces, very very tiny ones. If you're getting a bronchoscopic biopsy, at least ask for at least minimum give me 6 pieces for final confirmation, not less than that. Okay. So this is my reference. Please go ahead and read the latest CAP protocol and what is TAS, etc. It is very very important. I'll take it up when I take malignancies. And this is my book. I would request you all to buy it and to review it on the Ahuja book website. You just have to type this name and the name of the book and my name, And this is very, and I would be really really happy for your support. Just as you've supported my channel, please support my book also. And soon we'll be out with a benign hematology part of this book too. So I hope you like this, and I'll be back with the lesions in lung in my next week's lecture. Okay, so take care.